Good afternoon, Dr. Fishman. How's it going?
Hi, Carly. How are you doing today?
It's so good to talk to you again. I'm so excited to continue the series that we have going on here today. And it's all about mental health, how mental awareness, wellness, that all coincides. And there's actually quite a lot of synergy that has to do with chronic pain. I'd love to know how mental health, how it has to do with chronic pain, if there is any synergy. I'll kick it to you to get us started.
Thanks, Carly. Psychological aspects of pain care are incredibly important. And I would go to say that psychological aspects of healthcare are incredibly important. And I think we all know that your mental health and your ability to believe in yourself and to affect change in your life is critically important at various stages in development and maintenance of good health and wellness. When we think about chronic pain and pain problems, almost everybody will experience pain during their lifetime. So it's not whether or not you will experience, it's really how you will handle it and whether or not you will recover and what that recovery will be. When we look at pain across the board, it costs hundreds of billions of dollars and impacts 100 million Americans at least. When we think about chronic pain, oftentimes there is one main pain generator that leads to symptoms, but in many cases, patients have variety of different pain problems that all coalesce to ultimately develop their phenotype or how they present. When we look at chronic pain from a constructive model standpoint, we call it the biopsychosocial model of pain. That is, there's some biologic things that make you vulnerable to having a pain problem, like having a bad spine angle or having a hypermobile tissue and a variety of other things. There is psychological components, how you learn, how you cope with various components of your problem, the ability to have something we call self-efficacy and to be able to believe that you can accomplish things and then actually go out and achieve them. There is a social concept of this that goes in two directions. People with strong social networks and support. As social creatures, humans really rely on that in a family and also distributed friendship and healthcare network to be additive to their recovery. On the flip side, isolation can lead to other significant mental health challenges, and inherent to their both consequences and symptoms. Many pain conditions or chronically painful conditions are isolating by their nature. They prevent people from participating in social events. They prevent you from traveling. They may prevent you from being able to go into a car ride or even just walk to a neighbor's. And those micro changes and macro changes in socialization are incredibly impactful to the well-being of the individual. And a friend of mine, Dan Bates, said this once upon a time, that pain is a social disease, and it really is.
Wow. There's quite a lot of things here you can see on the chart that has to do with your mental health that directly contributes to your actual chronic pain.
It can go both directions, and I think this is really important. Your well-being or your sense of well-being could lead you to a path of resilience.
Mm-hmm.
Your sense of well-being could also lead you to a path of catastrophic thinking and symptom magnification. This can make you better or worse. And as a pain physician, as a chronic pain physician who treats people on a regular basis, it is inherently important that I get a sense of their well-being because it does influence their response to treatment. When we look at people who have a mood or a feeling, there are lots of moods and feelings. And those moods and feelings are all normal, actually. Almost in general, it's when they're out of context that they may be abnormal. But everybody feels surprised, feels bad, fears fearful, angry, disgusted, sad, or happy. I mean, we have all of these things.
Mm-hmm.
Depression, anxiety, and a host of what we call personality disorders may lead to, surprise, surprise, the inappropriate application of some of these moods and feelings to different aspects of life. And when you think about that, it really changes dramatically your ability to sometimes believe in yourself, and ultimately, as we described before, be self-efficacious. And so it's incredibly important to me that we give people tools. Sometimes they're medication tools, sometimes they're meditation tools, sometimes they're physical exercise tools, and oftentimes, in almost all cases, there's an element of support that's really important to help people understand contextually that it's okay to be stressed, tired, angry, and scared, but it has to be contextual. And if you have a problem that is consistently impacting your life, we need to figure out a solution so that you're able to feel that full range of moods and feelings and not be stuck in negative domains. Depression is not a mood or a feeling. It is a defined set of set of diagnostic criteria. And depression is really difficult to treat. When we look at a very large scale trial, something called the STAR-D trial, they saw that only about 36% of patients who were treated with a medicine for depression, an antidepressant medicine, got better or exhibited remission. What we found is that the next drug that they try, the percentage of patients who respond is a bit lower. And so it's really hard sometimes to find an antidepressant that works because you have to try medicines for several weeks at a time to even decide whether or not they're improving your mood. And on the flip side, to make sure that you're not having what we call treatment emergent adverse events or side effects that you just really don't like.
Mm-hmm.
We know that when you look across the board at people who are hospitalized, these are people who are hospitalized for any reason. You are in the hospital longer, 36% longer, if you have treatment resistant depression than if you have untreated depression. And the takeaway from that is that
Wow.
your ability to recover and your ability to believe in your own wellness does rely on your mental health. And pain care, just like any medical care, is influenced by that. So people who have tried a bunch of medicines, it is quote unquote, it is depressing
Of
to keep
course.
trying antidepressants and continue to be depressed.
Yeah, that's it almost feeds into the depression, which is a shame because it really is trying to help it and trying to aid to it. But that can certainly bring, your sense of hope further and further and further down as you try.
Many patients will try multiple antidepressants before they're able to notice an improvement in the depression related symptoms.
Okay.
When we look in Australia, they did a very interesting study, and they looked at a large group of patients, 13,000 people, who they have genetic data on these patients. So they have genetic samples, they know what their DNA looks like. And so you can start to think about maybe there are some particularities of different types of people that might make them more likely to respond to a particular antidepressant or not. And they looked at this in patients who were taking chronic pain. And what they found was that for people who had chronic pain, regardless of your DNA and your genetics, just having chronic pain made certain antidepressants much less effective. That included things like sertraline, escitalopram, and citalopram. These are very commonly prescribed antidepressants.
Mm-hmm.
What they saw in these patients with chronic pain was that the antidepressants amitriptyline and duloxetine and venlafaxine were positively associated with treatment effectiveness for both depression and for pain. And what I find very interesting about this is that we know that everybody responds and presents a little bit differently. Speaking of mood, the mood this week is definitely one in Philadelphia that could lead to significant changes in the way people feel as our Eagles go to the Super Bowl against the Chiefs of Kansas City.
That's right.
When we look at people who live with chronic pain, they are not regular people. Just like Eagles fans are not regular people. This population is really specific. And so when we define the population of people in Philadelphia, we say they like green. They like birds that fly and are patriotic. They like steak and cheese sandwiches. They like a variety of things that are classically Philadelphia. When we think about chronic pain patients, there's some things that we see in these people that are universal. If you have chronic pain, you have high pain intensity and you have high pain impact. That means that pain impacts a lot of the things that you do, the activities of daily living. There's obstacles to doing those things, and pain is a problem. This is a study we did where we looked at 20,000 patients and we looked at their profiles across a variety of different domains. It included anxiety and depression. What's really interesting is we found that these patients who live with chronic pain in general have high levels of pain and low levels of physical function. I think that's pretty obvious.
Right.
What we did find, though, is that they're scattered in terms of how many of them have moderate to severe depression. Many of them don't. And how many of them have, for example, moderate to severe anxiety. So when we do a cluster analysis, we start to see that people with chronic pain really fit into a variety of different categories. Some of them really don't have any problems with anxiety, depression, fatigue, sleep disturbance. They have high pain and high pain interference. We have some patients, when we look at them, who have low level pain in general, have low levels of all of these issues. When we see patients with high level pain consistently, they have high levels of anxiety, depression, fatigue, pain interference with activities of daily living, physical function, sleep disturbance, and all of that. We see some patients who have really just insomnia, and others who have very low anxiety and depression, but high levels of pain, interference, physical function, sleep disturbance, etc. It's really interesting to see that people do tend to cluster into one of these 5 clusters. When I think about what I can do as a pain physician, all of these different activities, interventions, procedures, shots, blocks, and burns are only useful if the patient's wellness is also being attended to and putting the patient at the center of care. And so, at our practice, we believe in yoga, we believe in meditation, we believe in, for those who are into it, the power of prayer. Positive thinking and social support is incredibly important. We take the time to ask people about their life and what they like to do for fun. And I'll tell you, the biggest red flag to me is if somebody doesn't do anything for fun, there's nothing they enjoy. I'm going to take extra time with that patient, and we're going to try and figure out a way to frame their potential problems and potential solutions in a way that manifestly includes their mental health and wellness.
That's interesting that you said a big red flag of yours when you see patients is if they have nothing to do for fun, that they have no hobbies. You actually take that very seriously in your practice when you diagnose or during your evaluation process.
It's a big red flag.
Yeah. What would be some key takeaways, Dr. Fishman, to leave a patient with, or some key strategies even to break this cycle and regain a sense of control?
That's a great question. And I think about pain in terms of the definition of pain that we have from the International Association for the Study of Pain, which really defines it as an unpleasant sensory and emotional experience. And if we're not taking care of the sensory and emotional experience associated with your actual or potential tissue damage, then we're not doing a great job. And ultimately, I think this comes down to a few things. One, patients don't want to talk about mental health. Providers don't want to talk about mental health. So you need to bring it up. We should be asking about it, but you need to bring it up. Number one. Number two, just because you're on an antidepressant doesn't mean it's working. Doesn't mean that you're a failure. It means that you're like a lot of people out there where the antidepressant doesn't really work when it's prescribed for them in the first or second or even third drug. And so having an opportunity to really think and reevaluate, are you on medicines already for depression or anxiety? Are they working? And if not, that's a conversation to have with the prescriber of those medicines and something to think about and do your own research. And lastly, realize that you're not alone. And when you're treating a chronic problem, isolation is oftentimes something that can be really quite a curse. Make sure you pace yourself, but do try and engage. Get out there, do the things that you want to do, and don't be disappointed if your expectations of where you used to be are not met by your current level of functioning, just set new expectations. There's nothing more disappointing than an expectation. So take care of your mind and take care of your body, take care of your mental and your physical health, and talk to your physicians about those challenging and uncomfortable conversations surrounding how you're really feeling inside. It might feel strange, but it can have significant impacts on your wellness, not just from chronic pain, but from any condition.
I think that's the best way to sum it up today. Those were amazing key takeaways and some incredible advice for anybody who's listening. So thank you so much, Dr. Fishman. Thank you so much for all of your time and just taking a second to address this issue, this connection with your practice. We can't thank you enough. Thank you so much for your day.
Go Birds!
Go Birds!